Good morning, everybody. Thanks for joining. Cindy and I were actually just talking. It's probably not the most exciting topic, but definitely a topic that requires a little bit of attention. And so I just want to take a few minutes today to talk about some of the work that we've been doing, looking at our IV access when it comes to both medical alerts and trauma activations. And so I'm going to just start by asking some questions. First question I'm going to ask is, the majority of patients in the code room require IV access. And I'm going to open this up for a poll. I kind of want to see what you guys think. Do you feel like the majority of what patients you see are going to need an IV? Okay. There's not many of us on here, so it's easy to share. Can you guys see the results?
Yes.
Two-thirds of you said agree. And pretty much right, when you look at trauma alerts and medical resuscitations, about 60% of all of our patients actually require access. Doesn't mean that we don't put access in more than that, but when you really look at it, only about 60% do. And actually, more of your medical alert patients are going to require IV access, meaning they absolutely have to have it, than some of your trauma patients. Next question, all patients need access with the same degree of urgency. Again, I'm going to open a poll. Except, Cindy, it doesn't go to the next question. Oh, there we go. Majority of patients in the code room. Oh, nope, that's the same one. All right. Well, hold on. Never mind. Never mind the poll. I think we all kind of can agree. Okay, that the patients, okay, go ahead and we can do. Yes. We all do agree that the patient, not everybody has the same degree of urgency in order to get access. Some of our kids obviously need it right away, where others, they can wait a little bit longer. Now, next question. There are times it's appropriate to go straight to an IO without even attempting a peripheral IV. Open to poll for that one. And yes, we all kind of agree that that is the case, that there are definitely some patients that we see that we shouldn't even waste our time trying to get peripheral access. And we'll talk a little bit more about that here in a moment. I believe the last question I have is, there is a small subset of patients in the code room that just require a blood draw without placing a peripheral line. And so basically that there are some kids in the code room who never knew need access. And once again, we all agree on that. Okay. All right, so how we kind of got to looking at this is, as we've done some video review, we have noticed that there's a lot of time and resources that are wasted on attempting to insert a peripheral line in an unstable patient. And when I talk time and resources, I'm not only talking about the supplies you use, but the amount of personnel sometimes that is standing around a patient trying to put an IV in when there is other care that needs to be delivered that goes kind of to the wait list as 3 or 4 people try to get IV access. The other problems we've noticed is that IV access attempts with or without lab draw can delay emergent or urgent care. And again, this goes back to what I was saying. There are times where we may have an IO in an unstable patient, and we can use that IO to give meds, give RSI meds, start fluids, but we're waiting to get it. We are using personnel to try to get another IV, and we're putting that on hold. And then finally, another identified problem that we see is that stable patients can experience too many IV attempts, especially when they're a heart stick. So as we've watched this and we've collected some baseline data, we've looked at Dr. Bird's full research that he does, which is decision-making and algorithms within trauma. And so we've worked with Karen O'Connell, And we've created a decision rule to assist staff in decisions around IV access. Some of these are going to make sense. Some of them cause us to stop and think a little bit. Now, here is the actual algorithm we've come up with, and you're looking at that going, wow, for, you know, like a 10-second decision, that's incredibly complex, and it definitely is overwhelming. And so basically, we're going to spend this time breaking it down and talking through the questions that we'll be asking ourselves as a team during a trauma alert or a medical resuscitation when we look at the need for IV access. And so the first question that comes up is, does this patient need access? And so what we tend to do is we look, and maybe we have EMS report, maybe we're looking at the patient, and we say, no, he arrived with access already in place. Well, if we have access already in place, the next obvious thing we need to do is check to see if that IV is patent. If that IV is patent, we've met our goal, and we have our initial access in which we can do emergent care. If that IV is not patent, then we have to go back to the original question is, does this patient need access? And so the potential answer there is yes, which moves us then to question 2. The second question we have is, does this patient have a GCS of 3, pardon the less than sign, seeing as you can't be less than? So is our GCS 3, is our patient hypotensive, or are they in cardiac arrest? If the answer to that is yes, these are patients that we should not be trying to get a peripheral line. Even though we're going to go straight to an IO, trying to get a peripheral line on somebody who's hypotensive or in cardiac arrest is actually a waste of resources, because you obviously do not have blood pumping to the peripheries very well. And especially in your trauma patients who are in hypovolemic shock, they're also very clamped down, meaning it diminishes blood flow to the extremities even more. If we say no to GCS of 3, hypotensive or cardiac arrest, moves us to the second question. Does this patient have a GCS of 4 to 8? Are they in respiratory failure, meaning are they bradykinin, bradycardic, or do they have SATs less than 94 on high flow? If we say yes to this, these are patients that require an immediate IO for access, so we can start treatment immediately. And these are patients that it may be worth our time to simultaneously having one person attempt IV placement. If we get that IO in, or we get that IV really quickly, then we've met our goal, and we have at least one access in order to be able to start treatment. Now, when we're looking at an IO and an IV, we also we don't get that IV, we're also looking at the fact that we have that IO for the initial treatment, but should we keep sticking and sticking to get an additional peripheral line? The answer to that is it depends. And so if you have that one access, now we need to look to the medical leadership to evaluate the need for an additional PIV. So do we take resources, you know, 1 or 2 people around the bed trained to get an IV and potentially a difficult patient to stick? Or are there other types of accesses that may be best suited for this patient, which may or may not be placed in the emergency department? Specifically, if it is placed in the emergency department, that could be a cordis catheter or trauma line, or it could be a central line placed either in the ED or when they get to the PICU. Now, if we say no, if our patient has a GCS higher than 8 and they're breathing okay, we go on to the next step. So question 4 is this patient tachycardic? Are they in respiratory distress? Meaning, are they tachypnic or tachycardic, and they have O2 sats greater than 94? If we say yes, these are patients that obviously do need access, but we also they don't need emergent access to where we would consider an IO at this point. And so the rule here is IV placement, 3 attempts over 3 minutes. And that is one person making 3 attempts, and they have 3 minutes in which to get that line. Failure to get that line in 3 minutes, well, if we do get it, it's successful. Failure to get that line in 3 minutes, this would be then to the medical leadership to consider IO if it's appropriate for that patient, or to evaluate the need for other types of access, which may be saying continue working on peripheral lines, or it may be looking at other forms of central access. If we can say no to the patient being tachycardia, respiratory distress, then we go to our next question. And this is, does my patient have a need for pain medication, antibiotics, CT contrast, or any other IV medications? If the answer is yes, again, that one nurse attempts times 3 over 3 minutes. If we get it in, we've successfully met the goal. If we do not get it in, this is a patient that none of these things are particularly urgent, and we could contact the IV team or a more experienced person to come in the room to put the IV in. And this kind of came out of looking at, the IV team had come to us asking to see if they had a place with trauma or medical alerts, if there was any way they could help. And sometimes the answer to that could be yes, but not in all occasions. If we say no, this patient has no need for pain medications, antibiotics, IV fluid, blood, doesn't need anything to go intravascularly, the last question we're going to ask is, does this kid need trauma labs? If the answer to that is yes, then we can forego the IV and we can obtain those labs with a butterfly needle, which is a lot easier to get than inserting a line. And if we say no, that there's no labs ordered, whether it's medical or a trauma lab, we can forego any attempts of access or phlebotomy and not stick that patient. So our hypothesis here is that this algorithm is going to help improve time to access in critical patients. The one hypothesis I don't have up here is that will also improve time to urgent care, whether that's RSI meds, blood infusion in these critical patients. And it will decrease the number of unnecessary IV attempts in patients who are stable or patients who require a second line with difficulty. Now, we know that this algorithm is not the end-all be-all. It is not something that is written in stone. It's for people to consider when they're trying to decide, do I put in a line or not? And probably the biggest thing to share is that one of the things that was noticed on video review when we talked about looking at these IV algorithms and the need is that we found that sometimes when people don't know what to do, they go to, let's get another line. And sometimes we end up with kids with 4 peripheral accesses when we could have been sufficed with 1, maybe 2. And so hopefully decreasing the need of sticks in kids that don't necessarily need it. I believe there's 4 of you, I think, on the call, or more than that on the call. I can open it to questions because I can imagine there's definitely some questions that people have on this. Because it's definitely a different way to look at how we practice in the code room. So if anybody has any questions? No questions?
Just one. It's not really a question, but just a thought that I definitely agree with the goal here. I think saying to have only one person try 3 attempts in 3 minutes, sometimes then that other nurse, like if it's the tech who's trying is nurse right and your nurse left, you're sort of standing there with nothing to do. So sometimes that's why the simultaneous attempts are occurring between nurse left and nurse right.
Absolutely, and it totally makes sense. I think what we need to keep in mind is that when we look at the number of sticks needed, because if we're not going straight to IO or IO and peripheral line simultaneously, these kids aren't emergent. They don't necessarily need emergent access. And so it may be to the patient's benefit that let's let nurse right see if they can get that. 3 minutes is not that long. Let's let them see if they can get that line. And decrease the number of sticks that we do on these kids, because these are kids that are feeling these sticks. And I'd rather, if I was getting an IV, I'd rather have somebody doing it on one side than having 2 people go at the same time, unless it was more on that emergent end in which we would be considering a different type of access. Does that make sense?
Yeah, I definitely see that point. I also think there's a role for the charge role, kind of monitoring the timeline too, and contributing to asking the medical team, is it time to reevaluate? So that also that kind of helps stay within the goal or reassessment of the need to continue of moving on for an IV.
Yeah, I couldn't agree with you more. I think this also comes back to good communication in the room, and that charge nurse being a leader in the room, and you're right, helping monitor that timeline and making sure that medical leadership, who often is distracted by other things, you know, they're getting the primary and secondary survey, they're, you know, ordering meds, what have you, depending on the patient's needs, and could easily not be paying attention to this. And it's something that the charge nurse could really bring to their attention. I also think it really is the success of this is going to be on the communication of the nurse who is attempting the IV to make sure that that leadership team really hears, I have it or I don't have it, and we need other options, because again, these are things that can easily get lost in the shuffle of a very chaotic room. I will share with you, so Dr. Bird's grant that we're on is looking at decision algorithms for many aspects of care, both in the trauma patient, and Karen O'Connell is very involved in this, so we can make it work for the medical alert side of things also, because so many of these decisions are not trauma specific. They're really any kid in distress. And so this is just kind of our first attempt of, let's look at a decision algorithm, let's put it in there. Eventually, a lot of these decision algorithms are going to be computer-based, and we'll be interacting with the room. That's a few years down the road, but just to kind of give you an idea of what we kind of think is there to come, and would help eventually with some of the communication and the shared mental model.
We actually do have a couple questions in the chat. You want me to read them out to you?
Yeah, please.
So this is more of a statement, but I think it's a challenge to have everyone stand around and not stick the patient.
And not stick the patient?
Yeah.
I think it's a culture. I think we've gotten into a culture, because if you think about trauma in the 80s and 90s, even the early 2000s, we were still going, every trauma patient gets two lines and fluid. But we know that research has shown us that not everybody needs fluid. I'm speaking for trauma, not medical alerts at this point. Not every trauma needs fluid. Matter of fact, very few of our kids need fluid. And when they do need fluid, it's not usually a crystalloid. It should be a colloid or a blood product. And so we've decreased the amount of infusions that we get. In the trauma world, I can also tell you that other than RSI, there are very few emergent meds that we give. And so again, it decreases the number of emergent sticks that we need. But because of old mindset, we're all still in that mind that we got it, this kid gets in, and we got to get these lines in fast. And so, you know, two of us, and I'm just as much to blame at a bedside, two of us are used to going and let's get the line, let's get it fast, and having, you know, 2 or 3 people starting to stick. So it is a culture change, and it is a different way of thinking about things. And when we're looking at this, when we're looking at the kid who is awake and alert, again, I want you to think about your child laying there, or even you laying there. If you're awake and alert, maybe you're a little bit tachypnic, but the thought of having people sticking you in 2 or 3 different places at the same time is really not emergent, and could actually put a patient in more distress than just that single IV going at you. It's part of that chaotic room. So, right, I hear where you're coming from. I think history dictates some of our culture, and this is a very different way of looking at things.
Emily brought up a really good point. She said, who knew starting an IV is such a culture change, but it totally is. It goes against all of my training to do a vena puncture in a kid without a line. And also listening it, I get that too, because what I was, especially in pediatrics, like if you're going to stick the kid, you might as well get a line at the same time. That way, if you need it, it's there. And I think it's a good point.
It's definitely a good point. And, you know, I've prescribed to that theory for years and years. But I've also spent now it took me a lot of time sitting and watching videos to really appreciate the fact that there are kids that are very stable that we do multiple sticks on, and the only thing we ever use that line for is blood. And, you know, I would have been the first person to tell you that, well, it's worth it because who knows? You know, I can't live in that, you know, who knows if they're going to start antibiotics? Who knows if they'll eventually need a pain medicine? But we have looked at chart upon chart upon chart, and there really is a subset of kids that mean nothing, you know, other than maybe a lab. That's where it comes down to discussion in the room. I don't think any one of us should be making those decisions on our own. Me as the bedside nurse, I'm not going to be like, okay, we're going to forego the line. I'm just going to do a butterfly. It's definitely a conversation I'm going to have with both the ED physician and the surgeon in the room as, you know, maybe we've had 3 attempts and we don't get the line. Do you think this kid's going to need anything infused, or could we get labs through a butterfly? Again, not a decision I would make on my own, a decision to have discussed within the team.
There's also a request for you to repost the slide with the complete algorithm.
Absolutely, and I can actually send that out because it's really hard to see that complete algorithm. I play with it a million ways, and there's no way on PowerPoint to get it pretty.
And then we had another comment that said, I think it might be easier in traumas to implement this post-COVID-19 with fewer people in the code room.
No, I absolutely agree with you. COVID-19 we started working on this obviously well before COVID-19 and decreasing number of people, and that does put a big damper and a big switch on how we practice, and so total agreement. And I can tell you, this is not something that we are going to be looking, I mean, we are going to be looking at on video review. It is going to be studied, but at least in the interim, and you know, especially during COVID as things reopen and who knows what happens next, people are not going to be getting emails going, oh my gosh, how dare you? You should have went straight to an IO, or you spent 4 minutes trying to get this IV. There's not going to be discussion or feedback along. These are just concepts that we started looking at and are now just starting to roll out and starting to kind of educate to as a means to look at adjusting our culture a little bit and increasing communication with IV access. You guys are the first people to see this. We have not shared this with the surgeons yet, although the ED attendings were invited to this. I don't think we have any on here, but Karen will be presenting that to them in some of their staff meetings also. So this is just kind of the beginning of the conversation. Again, we know not perfect, and as we start presenting this, as we start looking at it in video review, as people get more educated to it, we all know that this algorithm will probably shift a little bit. I have yet to do anything in my career where the first attempt was the final attempt.
And we have another statement that another kind of related thing that happened in the trauma stat attending last week is that we delayed intubation meds to draw labs off the line before giving meds. There was a discussion about when to maybe delay labs, which is something we're also not used to thinking about.
Absolutely, you know, and it's funny, I watched that video and I just, in my head, I'm watching going, stop drawing the labs, we need to give drugs. And absolutely, and that's why we're really looking at that. We have that one line and the importance of that one line and the priority of care with that first line that we give. Having that second line in a critical patient is great, but we have to make sure that we are prioritizing what to do. And in that trauma that is being referred to, I know the surgical fellow who was in the room, I actually heard him twice say, stop drawing labs, we need to give RSI meds. And so we need to be looking at that leadership, whether it's the charge nurse that's saying it or your medical leadership in the room, to help prioritize some of these things that are happening. And so that all kind of goes hand in hand.
Jen, do you want to wrap up and discuss a little bit of the work that you've done with the time from decision to intubate and how the IV relates to that? I think that's really interesting that this group might like.
Yeah, you know, and it's funny, that's one of the things that kind of led us to this algorithm is for the last few years, we have looked at decision to intubate to intubation, and we consider intubation done when we get our first end tidal CO2 on the screen. And so we actually do that through video, and there's many ways that we determine the decision to intubate. It helps when they're very clear about it, but they aren't always. And so what we have found is meds 9 out of 10 times are always ready, and we're not waiting on meds. Anesthesia is always ready. 9 times out of 10, when intubation is delayed, it is because we don't have we're having trouble getting IV access. And there have been times we look at a benchmark of 10 minutes. Anesthesia would actually like to drop it to 8 minutes. And we probably hit it about 70% of the time. So those times when we don't hit it, it is almost always because we do not have an IV. And when we review those, these are kids that would have benefited from an IO, whether it would be an immediate IO or an IO with simultaneous IV attempts. And we could have had that tube in a lot quicker. Because once those meds are given, anesthesia and our ED docs can usually have a patient intubated within 60 to 120 seconds. So it's really all about getting the meds to the patient. And we fixed a lot of that. So now we got to fix the IV. And that's the hardest thing, I think, to fix, because there's so many variables. Okay. Well,
I think and the last comment before we close is I think we need to look at QI work with IO insertion. There's a great deal of reluctance and inexperience.
Absolutely. And that's, I think, what we see, that when you watch video, you can see the hesitation. It's funny, you can hear the discussion about it, but when the tire hits the road or the needle hits the leg, you can see the hesitation based on just an experience. And the fact that, let's be real, we do not get unstable kids on a daily basis. And so this is not something that you can put a new person in the room and within a couple of weeks think that they're going to be 100% comfortable. And so it really will require some discussion within our teams and our competencies and our, not necessarily competencies, but comfort with insertion of IO needles and being able to put those in and manage those lines. So, thank you everybody for being on here. I really appreciate the conversation at the end. It was the part I was really looking forward to, especially with you guys being the first group that has kind of looked at it. Now as you go into the code room and you have this kind of in the back of your head, be thinking about this as you're taking care of these patients. And really, I welcome any feedback. If you're in a code room tomorrow and something happens and you're like, hindsight, I probably should have went for an IO, or hindsight, I wonder if this kid really needed an IV. I think those are discussions that I would love to keep having and getting feedback from everybody, so we can really kind of hone this down to how we can give the best care to kids in our code room. So thank you very much. Have a great rest of your day, and I will see you all later.
Thanks, guys.